All right, if you're a dental professional or student in the UK, you know that getting patient consent right is everything. So we're going to do an essential study guide today breaking down the crucial principles based on BDA guidance. Let's make sure you're absolutely clear on what you need to know. Okay, so here's our game plan. We're going to start with the absolute fundamentals of consent, then we'll break down what makes it valid. After that, we'll get into the really specific stuff, dealing with minors and assessing mental capacity, before wrapping up with the key legal cases that shape how you practice today.
Right. First things first. Why is consent so fundamental? I mean, it's not just a rule you have to follow or a form to get signed. It's the entire ethical core of what we do.
And here it is. This is the bedrock of all healthcare, respecting a person's autonomy. It's their right to choose what happens to their own body. Simple as that. Every decision, every conversation, it all comes back to this one powerful idea.
And you have to understand the consequences of getting this wrong are, well, they're severe. We're not just talking about a slap on the wrist. Any treatment without valid consent can be seen legally as assault. It can be a human rights breach. It can lead to investigations for serious professional misconduct and even criminal investigations. So yeah, getting this right every single time is absolutely crucial. So what does it take to turn a simple yes from a patient into consent that's actually legally and ethically sound? Well, it all rests on what we call the 3 pillars. For consent to be valid, you've got to hit all 3 of these criteria. It's like a 3-legged stool. Take one away and the whole thing falls over. It has to be voluntary, so given freely without any pressure. It has to be informed, meaning the patient has all the info they need. And of course, the patient has to be confident to make that decision in the first place. And let's be crystal clear about who's responsible here. It's you, the clinician providing the treatment. You can't delegate this. A nurse or receptionist can't do it for you. And it's not a one-time event. It's an ongoing conversation, even for referrals. The clinician accepting that referral has to confirm consent all over again.
Okay, now for a really critical area, especially for exams, how consent works for patients under 18. This can feel a bit tricky because the rules are tiered by both their age and their level of competence.
This timeline lays it out perfectly. Once a patient is 18, their autonomy is absolute. No one can override their decision. For 16 and 17-year-olds, they can consent to their own treatment, and here's the key part. A parent cannot overrule them. But it's for those under 16 where things get a bit more complex, and we have to assess their competence.
And that brings us to this incredibly important concept, Gillick competence. This isn't about their age. It's about the individual child. Do they have enough maturity and intelligence to fully understand what's being proposed, including all the risks and benefits?
So how do you actually make that call? Well, you're not just left to guess. The Freezer guidelines give you a practical framework. You need to consider these points. Do they understand the advice? Can you persuade them to tell their parents? Is their health going to suffer if they don't get this treatment? And ultimately, is it in their best interest to go ahead without parental consent? Now, if that child is not Gillick competent, then it's simple. You must get consent from a person with parental responsibility. And a word of warning here, that might not be the adult who brought them to the appointment. You need to be sure you're talking to the person with legal responsibility. Okay, let's switch gears and talk about adults who might not have the capacity to consent, maybe because of an illness or an injury. Your assessment here is absolutely critical. Now, what's really interesting here are the slightly different legal frameworks you need to be aware of. In England and Wales, you're guided by the Mental Capacity Act. In Scotland, it's the Adults with Incapacity Act. While they both focus on the patient's best interests, the guiding principles are different, so you really need to know which ones apply to the practice. So how do you actually go about assessing capacity? This isn't just about a gut feeling. The law gives you a really clear 2-stage test to follow every time. First, the diagnostic test. Does the patient have an impairment or disturbance of the mind or brain? If the answer is yes, then you move to stage 2, the functional test. And this is key. Does that impairment mean they are unable to make this specific decision at this specific time? Can they understand, retain, and weigh the information and then communicate their choice? Right, let's quickly cover the different forms that consent can take. It's not just one thing, and it's important to know the difference.
So you've got express consent, which is either verbal or written. And you've got implied consent, but be really careful with this one. A patient sitting in the chair implies consent for an exam, sure, but not for any kind of treatment. The gold standard, the one you always need to aim for, is informed and specific consent. That's the one that really counts. Okay, final section. And this is a big one for your exams. We're going to look at the landmark legal cases that have completely shaped our modern understanding of consent. It's a fascinating story, really, a journey from doctor knows best to a true partnership with the patient. You can see this incredible shift just by looking at this timeline. We start back in 1957 with the Bolam test, where basically the profession decided what was best. Then, slowly but surely, the courts began to shift the goalposts, leading up to the absolute game changer in 2014, Montgomery.
For decades, this was it. The Bolam test. It basically said that as long as you acted in a way that a reasonable group of your colleagues would find acceptable, you were in the clear. The focus was entirely on the profession's standards.
But the Montgomery ruling flipped that completely on its head. This is the modern standard, and it's essential you get this. The question is no longer, what would a reasonable dentist do? The question now is, what does this specific patient need to know to make their decision? The focus has shifted 100% from the clinician to the patient. And that leads to the idea of a material risk. So what is that? It's any risk that a reasonable person in that patient's position would think is significant. Or if you know something about that particular patient that would make a risk more significant to them. It's about what matters to that individual, not just some abstract statistic. So we'll end with this. This is the question you need to ask yourself every single day in practice. In light of Montgomery, is your consent process just a checklist of risks you read from a sheet? Or is it a genuine dialogue, a conversation centered on what your individual patient actually needs and wants to know to make the right choice for them? Because that is the standard you're measured against today.